Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. Today, we'll delve into immune-related extrinsic hemolytic anemias. Get ready to explore the fascinating world of blood cell destruction caused by the immune system. Let's dive in. Extrinsic hemolytic anemias can be divided into two categories: immune hemolytic anemia and non-immune hemolytic anemia. In both cases, the red blood cells, or RBCs, themselves remain structurally and functionally normal. However, external factors trigger their premature destruction. Let's first remind you about non-immune hemolytic anemias. These types of anemias, as discussed in the previous chapter, you can find the link to this video down in the description and on the right side of the screen now, result from physical or mechanical injury to the RBCs. Imagine tiny bumps, blows, or bruises that push these cells to their breaking point. On the other hand, immune hemolytic anemias occur when the survival of RBCs is shortened due to antibody-mediated mechanisms. It's like an army of antibodies attacking these innocent cells. But who are the culprits behind this immune assault? Well, the antibodies involved in immune hemolytic anemias can be of three types. First, we have autoantibodies, which target the RBC antigens within one's own body. It's like a case of mistaken identity, where the immune system turns against itself. Next, we have alloantibodies. These sneaky antibodies target RBC antigens in other individuals, causing an immune response when blood from different people mix. It's like a secret war happening inside our bodies. Lastly, there are antibodies against drugs taken by the patient. Yes, you heard it right. Some medications can trigger an immune response that specifically targets the RBCs. It's like a side effect that no one saw coming. But wait, there's more. Some of these antibodies activate the classical complement pathway. What does that mean? Well, it leads to complement proteins attaching themselves to the RBC membranes. And when these complement proteins get cozy with the RBCs, trouble brews. Macrophages, the cleanup crew of our bodies, step in and remove the marked RBCs. This process is known as complement-mediated hemolysis. However, when this hemolysis goes into overdrive, and RBC destruction surpasses the body's ability to replace them, we witness anemia. It's like a race between hemolysis and RBC production, and sometimes, the balance is disrupted. Immune hemolytic anemias come in different forms, such as autoimmune, drug-induced, and alloimmune types. Identifying the exact type is crucial for implementing the appropriate treatment strategies. Now, we unravel the fascinating pathophysiology behind this process. So, let's dive right in. In immune hemolysis, the drama unfolds when antibodies bind to specific antigens on the surface of red blood cells, or RBCs. This binding triggers the removal of these cells from circulation through two primary mechanisms, extravascular and intravascular hemolysis. The two main types of antibodies involved in most immune hemolytic anemias are immunoglobulin G, IgG, and immunoglobulin M, IgM. Picture IgG as a Y-shaped structure composed of identical heavy and light chains, while IgM takes the form of a pentamer, with multiple monomeric units connected by disulfide linkages. Now, let's talk about the classical complement pathway. It plays a significant role in immune hemolysis and involves a series of proteins designated as C1 through C9. C1 consists of C1q, C1r, and C1s components. When an antibody binds to an RBC antigen, C1q must attach to two adjacent Fc domains to activate the pathway. IgM, with its pentameric structure and multiple Fc domains, can activate complement with just one molecule. On the other hand, IgG antibodies require a sufficient number of molecules on the RBC surface for complement activation. It's like a teamwork requirement for the complement pathway to kick into action. It's important to note that subclasses of IgG have different abilities to bind complement. IgG1 and IgG3 exhibit high affinity for complement binding, while IgG2 and IgG4 have minimal binding capability. The binding of C1q to adjacent Fc domains sets off a chain reaction. C1r is activated, which, in turn, activates C1s. This complex then cleaves C4 and C2, leading to the formation of C4bC2A complexes that bind to the RBC membrane. These complexes act as active C3 convertase enzymes, cleaving C3 and resulting in the binding of C3b molecules to the RBC surface. The final step involves the conversion of C5 to C5b, which combines with C6, C7, C8, and multiple C9s to form the membrane attack complex, or MAC. The MAC creates a pore in the RBC membrane, allowing water and small ions to influx and leading to cell lysis. Hemolysis mediated by IgM antibodies can occur through both extravascular and intravascular mechanisms. When IgM molecules attach to RBCs in lower density, complement activation results in C3b binding. However, complement inhibitors prevent the full activation of the pathway. These C3b sensitized RBCs are primarily destroyed through extravascular hemolysis by macrophages in the liver. In cases of severe immune hemolysis with heavy RBC sensitization, excessive complement activation overwhelms the inhibitors, leading to rapid intravascular hemolysis. Hemolysis mediated by IgG antibodies predominantly occurs through extravascular mechanisms, with or without complement involvement. Macrophages in the spleen, equipped with receptors for the Fc component of IgG1 and IgG3, play a crucial role in removing IgG-sensitized RBCs from circulation. While IgG antibodies may not efficiently activate complement, a high density of IgG1 or IgG3 bound to RBC antigens can induce some complement activation. This results in faster clearance by macrophages in both the spleen and liver. Interestingly, partial phagocytosis of IgG-sensitized RBCs leads to the characteristic spherocytes, which are eventually removed from circulation by macrophages in the spleen's red pulp. And there you have it. The intricate pathophysiology behind immune hemolysis slowly unfolds, shedding light on the remarkable interplay between antibodies, complement proteins, and the remarkable immune system. In the next part of this captivating journey, where we'll conclude our exploration with a closer look at laboratory findings in immune hemolytic anemia, where the secrets of the blood reveal themselves. Let's embark on this scientific journey and uncover the intriguing clues. The laboratory findings in immune hemolytic anemia often bear resemblance to those of other hemolytic anemias. Key indicators include decreased levels of hemoglobin, increased reticulocytes count, elevated levels of indirect serum bilirubin and lactate dehydrogenase, and decreased serum haptoglobin levels. In cases of predominantly intravascular hemolysis or severe extravascular hemolysis, the haptoglobin level will be significantly reduced. Additionally, plasma hemoglobin levels may rise, and there might be evidence of hemoglobinuria or hemosideruria in chronic cases. The mean cell volume, MCV, may be increased due to reticulocytosis and RBC agglutination if present. We might also observe leukocytosis and thrombocytosis, indicating increased erythroid proliferation in the bone marrow. Examining the peripheral blood film may reveal interesting findings. Polychromasia, characterized by a variety of colors, can be observed due to reticulocytosis. Spherocytes, which are RBCs with membrane damage caused by macrophages and IgG antibodies, may also be present. Occasionally, RBC agglutination can be seen. Other noteworthy observations may include nucleated RBCs, fragmented RBCs or schistocytes, and the intriguing phenomenon of erythrophagocytosis, where phagocytes engulf RBCs. To determine if the hemolysis is immune-mediated, a direct antiglobulin test, DAT, is performed. The DAT helps detect the in vivo sensitization of RBC's surface by IgG, C3b, or C3d. Here's how it works. Patient RBCs that have been washed with saline are mixed with polyspecific antihuman globulin, AHG. If a critical number of IgG or complement molecules are present on the RBC surface, agglutination occurs, indicating a positive result. If the DAT is positive with polyspecific AHG, Further testing with monospecific anti-IgG and anti-C3b/C3d is conducted to identify the specific type of sensitization. In some cases, elution procedures may be used to remove the antibody from the RBCs for identification if IgG is detected. Determining the specificity of the IgG antibody involves assessing the reaction of the eluate with screening and panel reagent RBCs using the indirect antiglobulin test, IAT. This helps identify any circulating alloantibodies or autoantibodies that may be present. It's important to note that the DAT result may be negative in some cases of immune hemolytic anemias, and a positive DAT finding can also be caused by conditions other than immune hemolytic anemia. Therefore, the diagnosis of immune hemolytic anemia cannot solely rely on the DAT. A comprehensive approach that considers the patient's medical history, symptoms, recent medications, previous transfusions, coexisting conditions, including pregnancy, and the results of relevant hematologic, biochemical, and serologic tests is essential. Armed with these laboratory insights, healthcare professionals can unravel the mysteries of immune hemolytic anemia and provide appropriate care for patients. In the first category of extrinsic defects leading to increased erythrocyte destruction by immune causes is autoimmune hemolytic anemia, AIHA, where the body's immune system turns against its own red blood cells, leading to their premature destruction and resulting in anemia. Let's uncover the intricacies of this rare disorder. AIHA is characterized by the presence of autoantibodies that bind to the surface of red blood cells, RBCs, either with or without activating complement. It can affect individuals of all ages, with an estimated annual incidence of 1 to 3 cases per 100,000 people. The development of autoantibodies in AIHA can be attributed to various factors. These include dysregulation of the immune system, loss of immune tolerance, exposure to antigens similar to autoantigens, B lymphocyte neoplasms, or other unknown factors. The type, amount, and duration of antigen exposure, as well as genetic and environmental factors, may also play a role in the development of autoantibodies. The severity of anemia in AIHA can vary, ranging from mild to severe, and the onset of symptoms can be either acute or gradual. Several factors influence the severity of anemia, including characteristics of the autoantibodies, antigen characteristics on RBCs, and patient-related factors. Autoimmune hemolytic anemias can be categorized into 4 main types based on the characteristics of the autoantibodies and the mechanism of hemolysis. First, we have warm autoimmune hemolytic anemia, where autoantibodies react optimally at body temperature, 37 degrees Celsius, and primarily lead to extravascular hemolysis. In this type, RBCs are destroyed by macrophages, mainly in the spleen. Next, we have cold agglutinin disease. In this type, autoantibodies have optimal reactivity at lower temperatures, typically below body temperature. They can cause agglutination of RBCs in the peripheral circulation and extravascular hemolysis, mainly in colder parts of the body such as the fingers, toes, and nose. Paroxysmal cold hemoglobinuria is another type characterized by the presence of biphasic autoantibodies. These autoantibodies bind to RBCs in cold temperatures and later activate complement upon rewarming, leading to intravascular hemolysis and hemoglobinuria. Finally, we have mixed-type autoimmune hemolytic anemia. This category includes cases that exhibit features of more than one type of AIHA or do not fit into the other categories. These distinct categories help classify AIHA based on the characteristics of the autoantibodies and the observed patterns of hemolysis. Warm autoimmune hemolytic anemia, WAIHA, the most common type of autoimmune hemolytic anemia, accounting for up to 70% of cases. Let's dive deeper into the details of this fascinating condition. WAIHA can be classified into 2 categories, idiopathic and secondary. Idiopathic WAIHA refers to cases where the cause is unknown, while secondary WAIHA occurs in the presence of other conditions such as lymphoproliferative diseases, non-lymphoid neoplasms, autoimmune disorders, immunodeficiency disorders, and viral infections. The onset of WAIHA is usually insidious, with symptoms of anemia such as fatigue, dizziness, and dyspnea. However, in some cases, particularly in children associated with viral infections, WAIHA can present acutely and be life-threatening. Symptoms may include fever, jaundice, splenomegaly, and hepatomegaly. In adults, the presence of massive splenomegaly, lymphadenopathy, fever, petechiae, ecchymosis, or renal failure suggests an underlying lymphoproliferative disorder. Diagnosis of WAIHA involves the direct antiglobulin test, DAT, which is positive in over 95% of patients. Most patients have IgG alone or both IgG and complement component C3d on their RBCs. However, a negative DAT result does not rule out the possibility of autoimmune hemolytic anemia, which can occur in 1 to 4% of patients due to various reasons. Warm autoantibodies in WAIHA are typically pan-reactive, making it challenging to determine their specificity. Although specific autoantibodies to antigens in the Rh blood group system or other blood group antigens may be identified in some cases, for most patients, the autoantibody is pan-reactive, masking reactions of alloantibodies with RBC panel cells. Additional tests should be performed if an RBC transfusion is necessary to determine the presence of clinically significant alloantibodies. Laboratory findings in WAIHA reflect the predominantly extravascular hemolysis that occurs in IgG-mediated immune hemolysis. The peripheral blood film typically shows polychromasia and spherocytes. In some cases, WAIHA may be accompanied by immune thrombocytopenic purpura, resulting in a decreased platelet count, a condition known as Evans syndrome. The initial treatment of choice for symptomatic but non-life-threatening WAIHA is glucocorticosteroids, such as prednisone. Approximately 70 to 80% of patients show improvement with prednisone, but long-term maintenance dosage may be required. However, long-term steroid use is associated with serious side effects, and patients should receive appropriate supplementation and monitoring as recommended by the American College of Rheumatology. Splenectomy is an option for chronic WAIHA patients who do not respond to prednisone therapy or require long-term, high-dose prednisone. It achieves a favorable response in 50 to 75% of patients. Immunosuppressive drugs like cyclophosphamide or azathioprine may be used for refractory cases, and rituximab, a monoclonal antibody targeting B cells, has shown promising results with minimal side effects. In severe, life-threatening autoimmune syndromes including WAIHA and Evans syndrome, hematopoietic stem cell transplantation, HSCT, may be considered. Different sources of stem cells, such as autologous, HLA-matched sibling, or cord blood, have been used, but they carry risks. Managing the underlying condition in secondary WAIHA often helps control hemolysis and anemia, and RBC transfusion may be necessary in cases of critically low hemoglobin levels, although compatibility with the autoantibody can be challenging and should be closely monitored. With a range of treatment options available, the management of WAIHA requires a comprehensive and individualized approach. The second type is cold agglutinin disease, CAD, a condition characterized by the presence of autoantibodies called cold agglutinins, primarily of the IgM class. These autoantibodies have the peculiar ability to bind to red blood cells, RBCs, at temperatures below normal body temperature, resulting in their clumping or agglutination. While non-pathological cold agglutinins are commonly found in healthy individuals and have no significant clinical impact, pathologic cold agglutinins in CAD can cause hemolysis and lead to symptoms. In CAD, the IgM autoantibodies bind to RBCs in the colder areas of the body, such as the peripheral circulation and the vessels of the skin, where temperatures can drop to 30 degrees Celsius. Upon binding, the autoantibodies activate the classical complement pathway, leading to the deposition of complement component C3b on the RBCs. The RBCs then return to the central circulation, where the autoantibody dissociates, but the C3b components remain on the cell surface. This extravascular hemolysis is primarily carried out by hepatic macrophages that have receptors for C3b. In some cases, if the autoantibody has a high thermal amplitude or there is a deficiency in complement regulatory proteins, complement activation and intravascular hemolysis can occur. CAD can be categorized into two forms, acute and chronic. Acute CAD is usually associated with infections such as Mycoplasma pneumoniae, infectious mononucleosis, or other viral infections. The cold agglutinins observed in acute CAD are polyclonal IgM antibodies with a normal light chain distribution. The hemolysis in acute CAD tends to be milder and self-limiting, resolving within weeks to a few months. Chronic CAD, on the other hand, is a rare form of hemolytic anemia that typically affects middle-aged and elderly individuals. It is often idiopathic, with no known cause, but it can also be secondary to lymphoproliferative neoplasms, including B lymphocytic lymphomas, Waldenström macroglobulinemia, or chronic lymphocytic leukemia. In chronic CAD, the autoantibody is usually monoclonal IgM with kappa light chains. The symptoms and severity of chronic CAD can vary, with most patients having mild anemia and hemoglobin levels ranging from 9 to 12 grams per deciliter. However, some individuals may experience life-threatening anemia with hemoglobin levels falling below 5 grams per deciliter, especially after exposure to cold temperatures. Fatigue, weakness, dyspnea, pallor, acrocyanosis, bluish discoloration of extremities, and episodes of hemoglobinuria are common clinical manifestations. Diagnosis of CAD involves laboratory tests and careful interpretation of results. The direct antiglobulin test, DAT, is positive with polyspecific antihuman globulin, AHG, due to the presence of C3d on the RBC surface. The specificity of the cold agglutinin is most often directed against the I antigen but can also be against the I or, rarely, the PR antigen. Anti-I antibodies will agglutinate all screening and panel cells, donor RBCs, and the patient's own RBCs at room temperature and higher, depending on the thermal amplitude of the autoantibody. However, weaker or negative reactions may be observed with cord RBCs since they lack the I antigen. Cold agglutinin titer testing is performed at 4 degrees Celsius, and pathologic cold agglutinins can reach high titers ranging from 1 to 10,000 to 1 to million. Treatment options for CAD depend on the severity of symptoms. In mild cases or acute CAD associated with infections, no treatment may be required as the condition often resolves on its own. For chronic CAD with moderate to severe symptoms, treatment approaches include supportive care, avoiding cold temperatures, and regular monitoring of the patient. Rituximab, a monoclonal antibody targeting B lymphocytes, can induce partial remission in about half of the patients but typically provides temporary relief. In some cases, a combination of rituximab with fludarabine may be used. Plasmapheresis may be considered in severe cases, but its benefits are short-term. Corticosteroids, immunosuppressive therapy, and splenectomy are generally ineffective for CAD. In cases where RBC transfusion is necessary, precautions need to be taken to prevent in vivo reactivity of the cold autoantibody. Clinically significant alloantibodies should be ruled out before transfusion, and a patient should be kept warm during the procedure. Blood warmers can be used to minimize the reactivity of the cold autoantibody. The next stop in our journey is paroxysmal cold hemoglobinuria, or PCH for short. It's a fascinating condition involving the destruction of red blood cells in response to cold temperatures. Let's explore this rare and captivating topic together. PCH can occur spontaneously or as a secondary condition. While it was previously associated with late-stage syphilis, nowadays, it's more commonly seen in young children following a viral respiratory infection. Interestingly, PCH is quite rare in adults. In fact, it has been reported that PCH occurs in approximately 32% to 40% of children with autoimmune hemolytic anemia, with a median age of presentation around 5 years. Now, let's dive into the science behind PCH. The primary antibody involved in this condition is called the anti-P autoantibody, also known as the Donef-Landsteiner antibody. This antibody is an IgG hemolysin that binds to the P antigen on red blood cells, leading to the activation of the complement system and subsequent hemolysis. But here's the twist: complete activation and destruction of the red blood cells only occur when the temperature rises to 37 degrees Celsius. What's truly fascinating is that exposure to cold temperatures is not necessary for the hemolytic effects to manifest in the body. Although the reasons for this are not fully understood, the anti-P autoantibody binds optimally to RBC antigens at 4 degrees Celsius and has limited activity above 20 degrees Celsius. At higher temperatures, it dissociates from the RBCs, resulting in a low concentration in the blood, usually with a titer of less than 1 hour 64 minutes. So, what are the typical symptoms and signs of PCH? Do you have a clue? Let me know in the comments. In children, PCH presents with a sudden onset of symptoms such as fever, general discomfort, and pain in the back, legs, or abdomen. These symptoms usually occur 1 to 2 weeks after a respiratory tract infection. Other common signs include pallor, jaundice, and dark urine due to the presence of hemoglobin in the urine. The rapid onset of hemolysis leads to severe and rapidly progressing anemia, often with hemoglobin levels dropping below 5 grams per deciliter. When examining the peripheral blood film, doctors may observe certain abnormalities like polychromasia in spherocytes. But that's not all. They might also come across schistocytes, nucleated RBCs, anisocytosis, poikilocytosis, and erythrophagocytosis. Initially, leukopenia, which is a low white blood cell count, may be present, but later on, it can transition to leukocytosis, indicating a high white blood cell count. Additionally, laboratory findings consistent with intravascular hemolysis are typically present. To diagnose PCH, doctors often employ the classic Donner-Flansteiner test. This test involves collecting blood samples from the patient and using 2 separate tubes, one for the patient test and another for the patient control. The patient test sample is incubated first at 4 degrees Celsius for 30 minutes, allowing the anti-P antibody to bind to the P antigen and partially activate complement on the RBCs. It is then incubated at 37 degrees Celsius for 30 minutes, leading to full complement activation and hemolysis. On the other hand, the patient control tube is kept at 37 degrees Celsius for both incubations. Now, here's where things get interesting. If hemolysis occurs in the patient test sample incubated at 4 degrees Celsius and then 37 degrees Celsius, with no hemolysis in the patient control sample kept at 37 degrees Celsius, it indicates a positive test result for anti-P antibodies. In simpler terms, this means that the anti-P autoantibody is present. However, initial test results may be falsely negative due to low complement and/or anti-P antibody levels in the patient sample caused by brisk in vivo hemolysis. To increase the test sensitivity in detecting anti-P antibodies, patient serum can be incubated with complement and papain-treated compatible group O RBCs. Although PCH is a severe condition, the good news is that it tends to be self-limiting, resolving within a few days to a few weeks, with an excellent prognosis. Most patients experience severe anemia that can be life-threatening, necessitating blood transfusions until the symptoms resolve. And here's an interesting fact: since the anti-P autoantibody only reacts at lower temperatures and P antigen-negative blood is extremely rare, transfusing P-positive blood is typically considered safe. Wow, what an incredible journey into the world of paroxysmal cold hemoglobinuria. We've learned about the fascinating mechanisms behind this condition, its typical symptoms and signs, and how it's diagnosed and managed. Remember, PCH may be rare, but understanding these rare conditions helps us appreciate the complexity of the human body. Mixed-type autoimmune hemolytic anemia. It's a fascinating condition where patients develop both warm autoimmune hemolytic anemia, WAHA, and cold agglutinin disease, CAD. Let's dive into the details of this complex condition together. Mixed-type autoimmune hemolytic anemia is characterized by the presence of both warm and cold-reacting autoantibodies. Warm autoimmune hemolytic anemia involves the presence of IgG autoantibodies that react optimally at body temperature, 37 degrees Celsius. On the other hand, cold agglutinin disease is characterized by the presence of IgM autoantibodies that react optimally at cold temperatures, 0 degrees Celsius to 10 degrees Celsius, but can still react at higher temperatures, thermal amplitude greater than 30 degrees Celsius. It's important to note that not all patients with WAIHA and non-pathogenic cold agglutinin should be classified as having mixed-type autoimmune hemolytic anemia. The cold agglutinin must be clinically significant and react at temperatures above 20 degrees Celsius to be considered part of this condition. The hemolysis in mixed-type autoimmune hemolytic anemia can occur through a combination of extravascular and intravascular mechanisms. This means that red blood cell destruction can happen both outside and within the blood vessels. The disease course is typically chronic, with intermittent episodes of severe anemia. To diagnose mixed-type autoimmune hemolytic anemia, doctors often perform a direct antiglobulin test, DAT. The DAT results can be positive for IgG only, C3d only, or both IgG and C3d. These positive results indicate the presence of antibodies and complement components on the surface of red blood cells. Now, let's talk about the specific characteristics of the autoantibodies in this condition. The warm autoantibody in mixed-type autoimmune hemolytic anemia is typically pan-reactive, meaning it reacts with various antigens on red blood cells without clear specificity. On the other hand, the cold-reacting antibody in CAD usually targets the I antigen on red blood cells, having anti-I specificity. When it comes to treatment, the approach for mixed-type autoimmune hemolytic anemia is similar to that of WAIHA. The primary goal is to suppress the immune response and reduce the destruction of red blood cells. This is often achieved through immunosuppressive therapy, such as corticosteroids. Other treatment options may include immunosuppressive drugs, splenectomy, surgical removal of the spleen, and in severe cases, the use of rituximab or other immunosuppressive agents. The choice of treatment depends on the severity of the disease and individual patient factors. And that brings us to the end of our exploration of mixed-type autoimmune hemolytic anemia. In this segment, we'll be discussing a fascinating condition known as drug-induced immune hemolytic anemia, DIHA. This rare condition occurs when a drug triggers a sudden decrease in hemoglobin levels, leading to clinical and biochemical evidence of hemolysis. Let's delve into the details of this condition and explore its mechanisms together. The estimated annual incidence of DIHA is approximately 1 per million persons, making it a relatively uncommon condition. Over 125 drugs have been reported to cause DIHA, with antimicrobial, anti-inflammatory, and antineoplastic drugs being the most commonly implicated categories. Some specific drugs that have been frequently associated with DIHA cases in the past decade include cefotetin, ceftriaxone, trimethoprim, and piperacillin. DIHA can have severe and even fatal consequences. Hemolysis, or the destruction of red blood cells, can occur through extravascular or intravascular mechanisms. It is crucial for healthcare providers to be aware of the possibility of DIHA when patients experience a sudden drop in hemoglobin levels after drug administration, and to promptly discontinue the suspected medication. Managing DIHA involves discontinuing the offending drug and providing supportive care. In severe cases, blood transfusions may be necessary to treat the resulting anemia. In some instances, corticosteroids or other immunosuppressive therapies may be utilized to suppress the immune response and reduce hemolysis. Now let's explore the mechanisms behind drug-induced immune hemolysis. There are several proposed mechanisms, all involving the production of antibodies by the patient in response to drug exposure. The three generally accepted mechanisms are drug adsorption, drug RBC membrane protein immunogenic complex formation, and RBC autoantibody induction. In the drug adsorption mechanism, a patient produces an IgG antibody in response to a drug. When the drug is taken by the patient, it strongly binds to the patient's red blood cells. The IgG drug antibody then attaches to the drug-bound RBCs, typically without activating complement. This leads to extravascular hemolysis, where splenic macrophages remove the antibody and drug-coated RBCs from circulation. The drug RBC membrane protein immunogenic complex mechanism involves a drug loosely binding to an RBC membrane protein, forming a complex or epitope. The patient then produces an IgM or IgG antibody that binds to this complex on the RBCs, leading to full activation of complement and acute intravascular hemolysis. In the RBC autoantibody induction mechanism, a drug induces the patient to produce warm reactive autoantibodies, IgG, against the patient's own RBC self-antigens. These autoantibodies react at body temperature, 37 degrees Celsius, similar to warm autoimmune hemolytic anemia, WAHA. Hemolysis in this case is predominantly extravascular and mediated by macrophages, particularly in the spleen. Additionally, there is a proposed unifying theory suggesting that all cases of DIHA can be explained by a single mechanism. According to this theory, a drug interacts with the RBC membrane, generating multiple immunogenic epitopes. These epitopes can elicit an immune response against the drug alone, the drug-RBC membrane protein combination, or an RBC membrane protein alone. Different cases of DIHA may involve different combinations of these interactions. It's important to note that there is another mechanism called drug-induced non-immunologic protein adsorption, NIPA. In this mechanism, a drug can yield a positive direct antiglobulin test, DAT, result, but it does not induce the production of drug or RBC antibodies by the patient. The exact mechanism of NIPA differs from the immunologic mechanisms described earlier. To diagnose DIHA, a positive antibody screen and the presence of an antibody in the RBC eluate are required. Identifying the specific mechanism involved in a case of DIHA can help guide treatment and management strategies. Antibodies involved in DIHA can be classified into two main types, drug-dependent antibodies and drug-independent antibodies. Some drugs can induce a combination of both types. Drug-dependent antibodies are reactive only in vitro when the suspected drug or its metabolite is present. There are two subtypes, antibodies that react exclusively with drug-treated cells and antibodies that react only in the presence of the drug. The former are IgG drug antibodies that bind to drugs strongly associated with the surface of RBCs, leading to extravascular clearance by macrophages in the spleen. Complement activation is typically not involved. Examples of drugs that elicit these antibodies include penicillin and cyclosporin. The latter subtype includes IgG and/or IgM antibodies that bind to drugs or their metabolites weakly associated with a complex of drug and RBC membrane proteins. These antibodies activate complement and trigger acute intravascular hemolysis. Drugs like phenacetin, trimethoprim, quinine, and ciprofloxacin can induce this subtype of antibodies. Drug-independent antibodies are a type of antibody involved in DIHA that do not require the presence of the drug for in vitro reactivity. They are IgG, warm reactive antibodies induced by the drug through the mechanism of RBC autoantibody induction. Examples of drugs that can elicit drug-independent antibodies include fludarabine, methyldopa, and procainamide. In addition to immune-mediated mechanisms, drug-induced hemolysis can occur through a non-immune mechanism known as drug-induced non-immunologic protein adsorption, NIPA. Unlike immune-mediated hemolysis, NIPA does not involve the production of antibodies against the drug or red blood cells, RBCs. Instead, certain drugs can modify the RBC membrane, causing various proteins, including IgG and complement, to be adsorbed onto the RBC surface. This can lead to a positive direct antiglobulin test, DAT, result, although hemolysis is rare. The primary treatment for drug-induced immune hemolytic anemia, DIHA, is discontinuing the causative drug. Most patients will gradually show improvement within a few days to several weeks after stopping the drug. In cases where a warm-reacting autoimmune antibody is present, a positive DAT result may persist for months even after hematologic recovery. Severe cases of anemia may require red blood cell transfusion or plasma exchange. Regardless of the mechanism involved in DIHA, future episodes can be prevented by avoiding the specific drug that triggered the immune response. Identifying the culprit drug and documenting it in the patient's medical records is crucial to ensure avoidance in the future. Before we move to the next part of our video, we want to hear from you. Which of these diseases do you find the most serious? Leave a comment and let us know. Don't forget to subscribe, activate notifications, and share this video with your friends. Autoimmune hemolytic anemias. Specifically, we'll dive into hemolytic transfusion reactions, HTRs, and hemolytic disease of the fetus and newborn, HDFN. These conditions are not only severe but also potentially life-threatening complications of blood transfusions and pregnancies. So, let's embark on this fascinating journey together. Let's begin with hemolytic transfusion reactions, HTRs. These occur when the recipient's immune system destroys donor red blood cells due to the presence of antibodies in the recipient's body. These antibodies can be either IgM or IgG, and the activation of complement may vary. The hemolysis can occur either intravascularly or extravascularly, depending on the characteristics of the antibody. HTRs can have an acute or delayed onset, making them quite complex. Acute hemolytic transfusion reactions, AHTRs, typically happen shortly after a transfusion, usually within minutes to hours. The most common cause of AHTRs is the accidental transfusion of ABO-incompatible donor red blood cells into a recipient. Imagine, for example, transfusing Group A red blood cells into a Group O recipient. This mismatch triggers a rapid, complement-mediated intravascular hemolysis and activates the coagulation system. ABO-incompatible transfusions usually result from clerical errors and occur in a small percentage of cases. Although AHTRs involving other blood group systems are rare, they can still occur. Severe intravascular hemolysis, as seen in ABO-related AHTRs, manifests quickly and presents a range of symptoms. These may include chills, fever, urticaria, tachycardia, nausea and vomiting, chest and back pain, shock, anaphylaxis, pulmonary edema, congestive heart failure, and bleeding due to disseminated intravascular coagulation, DIC. Upon the onset of these symptoms, it's crucial to immediately terminate the transfusion. Urgent treatment focuses on preventing or correcting shock, maintaining renal circulation, and controlling DIC. When investigating a suspected HTR, several steps are taken. The first involves checking for clerical errors and examining a post-transfusion blood specimen for signs of hemolysis. Additionally, a direct antiglobulin test, DAT, is performed on the red blood cells in the post-transfusion specimen. In the case of AHTR, hemoglobinuria and hemoglobinuria may be detected, and the DAT result is positive. However, if all the donor cells are lysed, the DAT findings may be negative. Hemoglobin and serum haptoglobin levels decrease, but a rise in serum indirect bilirubin typically occurs 2 to 3 days after the episode. Repeat ABO and Rh typing, antibody screening, and cross-matching are performed on both the recipient and the donor blood to identify the blood group incompatibility. Coagulation tests, such as D-dimer, fibrinogen, factors 5 and 8, and platelet count, can help assess the risk of DIC. Now, let's move on to delayed hemolytic transfusion reactions, DHTRs. These reactions can occur days to weeks after a transfusion, often when the titer of alloantibodies increases. DHTRs typically happen in patients who have been previously alloimmunized through pregnancy or previous transfusions, although the antibody titer may have been below the level of serologic detection at the time of the transfusion. Upon subsequent exposure to the antigen, the antibody titer increases, resulting in an amnestic response. The antibodies involved in DHTRs are typically IgG, reactive at 37 degrees Celsius, and may or may not activate complement partially or fully. The Duffy and Kidd blood groups are commonly implicated in DHTRs. In DHTRs, the patient's antibodies bind to the transfused red blood cells, leading to extravascular hemolysis with or without complement activation. Several key indicators can point toward DHTRs. These include an inadequate increase in hemoglobin levels after transfusion, positive direct antiglobulin test, DAT, results for IgG and or C3d, evidence of hemolysis in the morphological examination, and an increase in serum indirect bilirubin levels. Management of DHTR involves close monitoring of kidney function, especially in acutely ill patients. Now, let's shift our focus to hemolytic disease of the fetus and newborn, HDFN. This condition occurs when an IgG alloantibody produced by the mother crosses the placenta and binds to fetal red blood cells expressing the corresponding antigen. As a result, the fetal spleen's macrophages clear these sensitized red blood cells through extravascular hemolysis. Gradually, anemia develops as a consequence. In response, the fetal bone marrow shows erythroid hyperplasia, and there is extramedullary erythropoiesis in organs such as the spleen, liver, kidneys, and adrenal glands. This process often releases nucleated red blood cells into the fetal circulation. If left untreated, severe in utero anemia can lead to generalized edema, ascites, and a life-threatening condition called hydrops fetalis. Interestingly, anti-KEL antibodies can cause anemia in a different way by suppressing fetal erythropoiesis. Among various causes of HDFN, Rh-HDFN is associated with the highest number of fetal fatalities. This occurs when an Rh-D negative mother has preformed anti-D antibodies, IgG antibodies reactive at 37 degrees Celsius, as a result of previous exposure to the D antigen. This exposure can happen through immunization during a previous pregnancy with an Rh-positive baby or from prior transfusion of Rh-positive blood products. In subsequent pregnancies, if the fetus is Rh-positive, the maternal anti-D crosses the placenta and binds to the fetal red blood cells expressing the D antigen. Consequently, macrophages in the fetal spleen clear these sensitized red blood cells, leading to anemia and hyperbilirubinemia. To assess the severity of fetal anemia in cases of suspected severe fetal anemia and HDFN due to anti-D, various methods can be employed. Although invasive and carrying some risk of fetal loss, amniocentesis can accurately predict severe fetal anemia. Another approach is percutaneous umbilical fetal blood sampling, which involves obtaining a blood sample from the umbilical cord and testing it for hemoglobin levels. Recently, non-invasive assessment of anemia has also become possible using ultrasound measurements of fetal cerebral blood flow. These methods aid in determining the severity of the anemia and guide appropriate management strategies. Laboratory findings. In the context of hemolytic disease of the fetus and newborn, HDFN, various laboratory tests are conducted to assess the mother's antibody status and to evaluate the newborn for signs of hemolysis. During pregnancy, the mother's ABO and Rh typing, as well as an antibody screen, are typically performed between 10 and 16 weeks of gestation and again at 28 weeks of gestation. The antibody screen aims to detect any antibodies other than those caused by ABO incompatibility. If the antibody screen is positive, an RBC panel is performed to identify the specific antibody involved. In cases where the initial antibody screen is positive, subsequent antibody screens are performed monthly until 28 weeks of gestation, and then every 2 weeks thereafter. Antibody titers are monitored and reported from each sample. It's important to note that the titration of the antibody does not predict the severity of HDFN but helps determine when additional monitoring methods should be employed, such as spectrophotometric analysis of amniotic fluid bilirubin. After the first affected pregnancy, the antibody titer is no longer useful for monitoring, and other methods like amniocentesis and ultrasonography are utilized. In pregnancies where the mother is Rh negative and unimmunized, antenatal Rh immune globulin, RHIG, is administered at 28 weeks of gestation and again within 72 hours after the delivery of a D-positive infant. This administration of RHIG reduces the risk of the mother developing anti-D antibodies and having a child with HDFN in subsequent pregnancies. At the time of delivery, laboratory testing is performed on umbilical cord blood from the newborn. Testing includes ABO, forward typing only, Rh typing, and a direct antiglobulin test, DAT. Neonates with Rh-HDFN typically present with a decreased hemoglobin level, increased reticulocytes count, and elevated serum indirect bilirubin levels. The peripheral blood film may show polychromasia, increased variation in RBC color, and the presence of nucleated RBCs. The DAT result is positive for IgG antibodies, and anti-D can be demonstrated in an eluate of the infant's RBCs. These laboratory findings help confirm the diagnosis of HDFN, assess the severity of hemolysis in the newborn, and guide appropriate management strategies. Hemolytic disease of the fetus and newborn caused by other blood group antigens. Hemolytic disease of the fetus and newborn, HDFN, can also be caused by other blood group antigens apart from ABO and Rh systems. ABO HDFN is more common than Rh disease and typically occurs during the first pregnancy. Unlike Rh disease, ABO HDFN is often asymptomatic or presents with mild hyperbilirubinemia and anemia. It can occur in infants born to type O mothers who produce IgG antibodies against A and B antigens, which can cross the placenta and affect the newborn's red blood cells. However, the disease is usually milder compared to Rh-HDFN. This is attributed to the fact that A and B antigens are poorly developed on fetal and newborn red blood cells, and other cells and tissues express these antigens, which reduces the amount of maternal antibodies directed against fetal red blood cells. The direct antiglobulin test, DAT, result for newborns with ABO-HDFN is weakly positive or may even be negative. Typical findings on the peripheral blood film include spherocytes and polychromasia. In addition to ABO-HDFN, HDFN can also be caused by other IgG antibodies, particularly antibodies against the KEL, K, C, and Phi antigens. However, HDFN due to other blood group antibodies is rare. Early antibody screening during the first trimester of pregnancy can help identify these rare antibodies that can cause HDFN. The adverse clinical outcomes of HDFN, regardless of the underlying antigen, can include varying degrees of anemia, jaundice, and, in severe cases, kernicterus, bilirubin accumulation in the brain. It is important for healthcare providers to perform regular antibody screening during pregnancy and monitor infants for signs of HDFN to ensure timely management and intervention if necessary. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.